A lot of folks feel that if the patient has enough runway, meaning if they have relatively indolent or slow-growing disease, since immunologic therapy provides a plateau on the curve and the hope that you've actually cured some of the patients, you should always go with immunologic therapy first and then come with the targeted therapy in a BRAF-mutated patient, of course, later. There are some data supporting that at Harvard, which is the Dana-Farber, the Beth Israel, and Mass General. They've got an article that I've heard about circulating around that's been submitted, where they have 200 some odd patients who either got immunologic therapy first, then the BRAF inhibitor next, or they got the BRAF inhibitor first, then the immunologic therapy. The patients who got BRAF inhibitor first, then immune therapy did poorly, very short progression-free survival. Most of them died quickly after failing the BRAF inhibitor. With the patients who got immunotherapy first, they had just as good a chance of getting a response to the BRAF inhibitor and just as good a survival as if they had started out only with the BRAF inhibitor at the get-go. The implication being you may be better off starting with immune therapy, even in a BRAF-mutated patient, than going to the targeted therapy. And that's going to be put to a test in a cooperative group trial. So it's just a hypothesis, but I would say it's the current urban legend in the oncology field in melanoma that if you fail a BRAF inhibitor, you're going to have a very short survival. You won't even have time to respond to immunotherapy. So use the immunotherapy up front, then go to the BRAF or BRAF-MEK combination.